I'm Sundeep Kheterpal from the Windsor Eye Clinic, and I started using the Rayner EMVs in the spring of this year, and to date I've done 31 eyes in 27 patients. I've had a little journey. When I start a new lens, I tend to start on myopes because I find that lets me test my biometry and my outcomes. So I started with a couple of 2 myopes at -2 to try and enhance their near vision. And there are only 2 patients, so they were both happy with their outcomes. I was happy with my biometry. So then I progressed to doing some other myopes. In fact, I've done 3 patients who were at -1 and -2. I've called that indoor myopia. And those were very happy patients. There were 2 wheelchair-bound patients and one who worked indoor, actually in a pub, and wanted to have indoors vision and didn't drive very much. So these were very happy outcomes. And it's quite a nice way to test your biometry and to test your ability to blend vision if you've not had experience in that before. The majority of my patients are second eye pseudophakics. I've done a large number of patients who have had pseudophakia in one eye from a different lens company and then putting the RayOne in the second eye, and a smaller number doing the RayOne in both eyes. So those outcomes are generally very pleasing. The patients in whom we're doing the second eye with the RayOne, targeting between -0.6 and -0.9, have generally ended up with very good intermediate vision, consistently between 6.9 and 6.12, and some of them with quite good arm's length reading vision as well. Yes, the surprise really is that from my experience in working in vision correction, in laser surgery, and in doing pseudophakics for a long time, is that if you generally aim for -1 with standard monofocal lens implant, patients find it very difficult to be satisfied. They don't get adequate distance vision. The intermediate vision is quite a limited range because they don't get closer table vision or arm's length reading vision. But the surprising thing is the wow that you get with these lenses. We all get happy patients after cataract surgery and hopefully most of the time after vision correction surgery. But the patients do come in happier than you would expect, and you get a bigger wow factor at the intermediate and the closer range of vision that in fact you get. And the tolerance of the distance blur is actually quite pleasing, and that's a surprise as well. So far, I haven't had any problems with the patients. The majority of the ones I'm talking to about this evening have had their surgery done before September and October of this year, so there's not been a lot of nighttime encounters. I do counsel all these patients. I do think if you are targeting around -1 or -0.75, patients will notice it if they cover their dominant emmetropic eye. So I think it's incumbent upon you to actually explain to the patients beforehand that they're going to get some distance blur. And I tell the patients they may need a pair of driving glasses for driving at night and a pair of computer or reading glasses. So we don't promise spectacle freedom, just a high degree of independence, particularly for indoors and for intermediate vision. So I haven't seen any problems so far, but we haven't gone through significant numbers of patients through the winter months yet. I think there are 2 categories of patients. There are the patients in whom you're doing cataract surgery just for visual impairment and in whom don't have significant other pathology. I have to say that I've done a large number of these patients who have either mild glaucoma, mild AMD, or small amounts of still less than 0.8 diopters. So you can do it with a little bit of other pathology, and these lenses, they're quite forgiving. So you can increase the range of patients who are suitable in the cataract population. So for those patients, I'm now routinely offering it them as an option to try and increase their intermediate vision. And so you can actually expand the number of patients that you're using in your standard cataract pool. If you've got a patient population coming in for vision correction, then they are I'm offering it as part of the range of options. I mean, multifocal lenses, whether it's bifocal, enhanced depth of field, enhanced depth of focus, and so on, are all good options and work very well in certain individuals. And with the EMV lenses, you won't get such a high degree of spectacle independence, but you won't get such issues with patients suffering from visual aberrations as well. So it's one of the range of options for vision correction patients, particularly those who are not suitable for multifocal lenses, or those patients who are not so worried about having to top up with a pair of glasses for the smallest print. I'm routinely offering it to the majority of my standard cataract patients who don't have a lot of other pathology, as an option to improve their intermediate vision. I think in some centers, it depends on how the center prices up the lenses. In patients who want the best range of EMV, then a RayOne lens in both eyes would be the appropriate way forwards. But there are some patients who are quite price sensitive, and actually as a strategy, and as I say, the majority of my patients who I've done so far have been in this category, have had a standard monofocal lens from whichever company you choose in the dominant eye, and put a RayOne in the second eye, and with very good outcomes and very good satisfaction levels amongst the patients. So in terms of increasing number of patients who use this and get a satisfactory result, you can offer it as the second eye routinely, and that cuts down the cost for patients in some centers. So that's a good strategy. So yes, routinely is my second eye in patients with cataracts at the moment. I think there are great options for patients who want to increase their intermediate range, or even in myopes who want to increase their near range as well. I mean, the things that we look out to start with are, we all say when starting out with any new lens, make sure that you're happy with your biometry and your calculations, so that you get pretty much what you're targeting for. I mean, you must use one of the new formulas that are available. When I do biometry calculations, I use at least 5 or 6 different formulas to make sure I counter check them. We also check the cylinder on more than one piece of equipment. So these lenses are moderately forgiving, but if you're trying to give better vision, then you can do sort of up to 0.8 diopters of SIL without too much concern. If you're getting 0.9, 1.1, then you can go ahead with LRIs. At the moment with the EMV, there's not a toric version available. And so that's something to bear in mind. I think myopia is a great way to start, whether you do one eye, both eyes myopia, and the patients that I've done, the 3 patients I've done with what I call the indoor myopia, -1 and -2, I've had very happy results, and they just require glasses when they're driving or when they're walking around the far distance. So that compares very well to standard monofocals, for which if you target -1, you end up pretty much with a middle of nowhere result. So patients don't tend to be happy. So that's a significant improvement. So I tend to target the non-dominant eye. I do test dominance. I don't do monovision trials. I know some colleagues are advocating increasing the degree of myopia in the non-dominant eye to -125 or -150. I think that, of course, increases some satisfaction in some patients. I think you have a risk with that if you significantly undercorrect or overcorrection if you become too myopic, particularly in hyperopes who are going to miss the distance acuity. And I think that you're in the territory when you're hitting -1.5, 1.75 of having to do a monovision trial beforehand. Whereas if you're -1, just under -1, like 0.8, 0.9, you don't need to do a monovision trial, as long as you tell the patients about distance blur and not to compare both eyes by covering each eye separately, that they understand that the nearer eye is going to have a little bit of distance blur, but not to compare the two. I think if another way of explaining it to patients who are starting is that one eye will be predominantly for outdoors and one for indoors. But again, a little bit of caution for going too myopic in the non-dominant eye. I think that's satisfactory if you have a laser top-up option in your clinics. But otherwise, if you don't go beyond -1, I think you'll have some happy patients. I think that the next questions are really, where does this fit into vision correction? As I said earlier, the multifocals are still great for some patients. This will increase the options. And the next thing that we need to look at really is whether it will be good for the holy grail population or hemetropic presbyopes to use in a non-dominant eye, in a single eye perhaps, move -1, maybe 1.25 as an option, instead of having uniocular LASIK or uniocular bifocal or trifocal lens implants. And that will be an interesting group of patients to try out. I still think we should do a monovision trial beforehand, particularly with the hyperopes, but I think it certainly increases the range of options.